Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges, and management option. For this webinar, today we have with us our guest speaker, and I would like to take a moment to introduce him. Today, we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune and has an experience of 38 years in this field. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune. Also, Dr. Pramod Jog was ex-president of Indian Academy of Pediatrics in 2016. He is an ex-standing committee member of International Pediatric Association and ex-steering committee member of Gavi. Dr. Pramod Jog practices at Jog Children's Clinic in Pune, and he completed his MD Pediatrics as well as MBBS from BJ Medical College, Pune. With this introductory note, I'll request Dr. Pramod Jog to take over. Over to you, sir.
Thank you, Manohar. I will just start sharing my screen, and I hope my screen is visible. And am I audible?
Yes, your screen is visible as well as you are audible, sir. You can start.
Thank you. So, my dear friends, today we are going to discuss the topic, what is new in flu? Okay, actually flu is not new, because we know that there have been 4 major pandemics in the world related to influenza, and the first pandemic was in 1918-19. That was called as Spanish flu, and it affected almost 500 million people. That is almost 1/3 of the world's population, and at that time 50 million people died. Second epidemic, rather pandemic, came in 1957 when it was H2N2. The third one in 1968, which was H3N2. And in 2009, all of us witnessed the swine flu pandemic. And now, today, we are not having any pandemic, but every year, this flu virus changes its structure. And that is why we have labeled it as a new or a novel influenza, which usually creates problems every year. You can see that Dr. Pramod Jog's name has been put in the way in which we give the nomenclature to the influenza virus. So it is Z/Pune/8/1958/PP, which indicates nothing but the type of the virus, the geographic location, the strain number, the year of isolation. So this is the way in which you can also put your name, and you'll find it quite interesting. And I have been the president of IAP, and I call myself as the 2016 strain of IAP president. With that, I must tell you that recently a 3-year-old boy came to the clinic with fever, cold, cough, and the child was progressively breathless over 3 days. He was tachypneic, and the blood gases showed basically acidosis, and saturation was 85% at room air. If you see the X-ray, you will find that it's a typical picture of ARDS. And he was admitted to PICU. He was ventilated. He was given Oseltamivir and supportive treatment. And the throat swab showed H1N1 positivity. He was ventilated for 3 days, and then he improved. Now, the question that many of my colleagues asked as to whether in the beginning, when he started getting fever, cold, and cough, whether Oseltamivir would have been started early. Okay. So when he was previously healthy, and at that time when he had cough, cold, and fever, and when he was showing progression over 3 days, whether this progression would have been prevented, and whether every patient of cough, cold, and fever be given Oseltamivir upfront, particularly in the flu season. And that is the confusion. That is the confusion related to flu in the minds of many of our colleagues. When we are unable to prove it by the nasal swab, are we justified in giving Oseltamivir in the initial 2 or 3 days? My dear friends, let me answer you this question straight away first. Whenever there is influenza in the atmosphere, when there are reports that you are getting H3N2 in the nasopharyngeal swab in majority of the people in the community, if the person presents with flu-like symptoms, particularly like headache, muscle pain, weakness, and high fever with chills, you are fully justified in giving Oseltamivir as an empirical therapy, because it is known that Oseltamivir reduces the duration of illness by almost 48 hours. It also prevents complications, hospitalization, and mortality. And that is what we are going to discuss today. Now, the first thing is whether this infection which the child has is bacterial or viral. Now, all of us are aware that viral infections usually affect more than one system. For example, a child who has respiratory viral infection will have cold, he will also have cough, he has discharge from the eye. At the same time, he might have diarrhea. At the same time, he might have rash. Okay. So more than one system is involved. While bacterial infections are localized. So the child who has tonsillopharyngitis does not have pneumonia. Okay. So a child with viral infection, you give paracetamol for fever. Fever comes down and the child starts playing as usual. And the mother is very, very happy that the medicine has taken care of the symptoms. However, in bacterial infections, when fever comes down after giving paracetamol, the child still does not become playful. He is dull, appears sick, even in the interfebrile period. And that is how we have to differentiate these two. Whether the infection, which is viral, is rhinovirus, or whether it is adenovirus, or whether it is influenza, we cannot say that. In fact, I always say that even Rajnikant cannot identify which is the virus producing fever, cold, and cough. And I will give you some clues as to how to identify some of these viruses in a minute. And if it's influenza, whether this is H1N1 influenza or H3N2. For your information, remember that H3N2 is supposed to be more severe as compared to H1N1 in general. And my dear friends, whether one should start Oseltamivir upfront and whether I should give every patient an antiviral to play safe. So these are some of the questions which are at the back of our mind, and we'll try to answer them while understanding the flu, its complications, and the management in particular relation to Oseltamivir. And recently, a small little girl came to the clinic with a doll in the hand, and she was constantly speaking to the doll, saying, don't worry, it is viral, it is viral. And then when I was laughing at the small little daughter, I started thinking after the clinic hours that gone are the days when we were, relatively not very worried when, we found that this is a viral infection. But now, when we find that this is virus, then I am little worried. And why I am worried? Because in the post-COVID period, we have started witnessing different kinds of viruses. For example, the wave of hand, foot, mouth disease, which affected in the months of July and August last year. Then the respiratory syncytial virus, which came in the beginning of the winter. Then the measles cases, which increased in the months of December and January. And then the H1N1, then the adenovirus, and now H3N2. So these different viruses were hiding themselves somewhere or the other. And children were not exposed to those viruses because they were all at home during COVID period and the schools were closed. When children started mixing up with their friends, when the schools started, these viruses, those who were not able to attack the children till now started attacking them, and children started getting different kinds of viruses. Okay. And what we see is even older children are getting affected in the post-COVID period. So the picture in the OPD these days is a bit different. So we are witnessing children who are coming to us with recurrent respiratory infections. We are witnessing patients who have otitis media and adenoidal hypertrophy. And as I told you, influenza, the disease which is usually seen in the monsoon months and in the post-monsoon period, has started showing its presence even unseasonally in the months of February and March. Adenovirus has become a bad adenovirus. It's become really bad because for so many years we have been discussing about adenovirus, and my teacher, I remember, he used to ask us a question, which is a respiratory virus which has more of non-respiratory manifestations, because all of you know that adenovirus produces fever, cough, and cold. It produces exudative tonsillitis, pharyngoconjunctival fever, and pneumonia and effusion. In addition, it produces diarrhea. In addition, it produces mesenteric adenitis and hemorrhagic cystitis. So it shows varied presentation. And adenovirus usually would be controlled in 4 or 5 days, but now it takes 7 or 8 days. So really, when parents come to me for the second time saying, sir, 3 to 4 days are over, but the child is really not improving, fever still continues, then I have a tough time telling them that this is adenovirus and don't worry. And many of your colleagues, if they are not aware of this fact, they would use antibiotics on day 3 or 4 or 5, and they won't get any relief because it's a viral illness. So by the end of the day 8, very few pediatricians would be really patient not to give antibiotics, and that's a problem. So it has become a prolonged illness, and there is a diagnostic dilemma, because till now we thought that only bacterial infections will lead to neutrophilic leukocytosis and increase in the CRP and so on. But now remember, adenovirus also produces rise in CRP. We have seen that influenza, COVID, they also produce rise in CRP. We never used to send so many nasopharyngeal swabs till now. But now, when we are in a dilemma, when we are puzzled, when we are confused, we have to send nasopharyngeal swab. This is important because we are discussing what is called as diagnostic stewardship. What do you mean by diagnostic stewardship? Just as we have antibiotic stewardship, that means we have to use antibiotics properly and preserve antibiotic use, avoid antibiotic abuse. Similarly, when you do certain tests, you have to be very sure as to what is the stage at which you do the nasopharyngeal swab and which are the patients in whom you do nasopharyngeal swab. So if you are not getting any diagnosis at day 5, and if the child is worsening and the child is developing lower respiratory symptoms and is hospitalized, you are fully justified in sending the swab for either flu or for COVID or for adenovirus. And there is a therapeutic dilemma, which means that antibiotic use, anti-flu medication use has to be monitored. Okay. We have also seen over the last few months the use of meter dose inhalers and the nasal steroids, which has gone up. So with that, this is a child named Viru. Viru, because it was a case of viral infection, came to me for fever for 3 days with cold and cough. He was on meter dose inhalers since last 4 months. The problem was very well controlled with symptomatic treatment, and I came back again after 3 days. He was afebrile for a day and fever again came up, and in fact, he was active in between. So clearly, this was a case of viral infection. Now, these recurrent viral infections which are coming up have become more frequent and they are occurring at shorter interval. And obviously, we will not be giving any antibiotic for these patients who are coming with recurrent respiratory infections which are viral in nature. However, you have to counsel the parents. When a child comes to you repeatedly, you have to just ask them 1 or 2 important questions, whether 2 to 3 weeks before, how was this particular child? If he has been unwell for almost 2 to 3 weeks without any gap in between, you have to suspect bacterial sinusitis. Okay. But if there has been a clear-cut gap, child without any fever, 5, 6, 7 days, absolutely playful and healthy child, then you have to tell them that this is recurrent viral infection, also known as back-to-back viral infection. And then the parents should be told that the adenovirus and other viruses have changed their structure, behavior, and that's why we are able to get it little prolonged. Many times what I do is I know that the adenovirus takes little longer. So I tell them that this particular child will take almost 2 weeks to settle. And if this settles within 8 or 10 days, then the credit goes to Dr. Jog, because then, the child has settled earlier and parents are also happy. But tell them in the beginning that the viruses are showing a varied presentation. And for that, my dear friends, you must be able to make an educated guess. What is this educated guess? It means that you should be able to guess the organism by simply looking at the child. For example, if a child has only runny nose, you have to suspect rhinovirus. Remember, the nose is affected almost always by the viruses. However, tonsillopharyngitis in 70% cases is viral. The rhinovirus, the influenza, the RSV, adenoenteroviruses, all of them attack the throat, and almost in 70% cases it is viral, while bacterial tonsillitis is in 30% cases, and the major one is, of course, the group A beta hemolytic streptococcus. And in case if you find that the pneumococcus and Hib are isolated from the throat swab, don't worry, because they are colonizers. They are going to be there. They are harmless in the throat swab. They are not the pathogens. Okay. However, you must be able to identify the enemies. Remember, in case if a child has otitis media or he has sinusitis, 70% of them are bacterial, while 30% are viral. And pneumonias, again, in majority of the cases are viral. However, a few of them are bacterial, particularly related to the Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. All of us are aware of it. So, when the onset is with cold and sneezing, then you should always suspect rhinovirus, where the child will have common cold, upper airway involvement, mild fever, no exhaustion, and the child will play well. This can also happen with influenza, parainfluenza, RSV, and so on. Along with high fever, if the child has prominent headache, muscle pain, extreme exhaustion, then you should always think of influenza. I told you about the different pictures and presentations of adenovirus in the form of pharyngoconjunctival fever and so on. Less than a year, you must suspect bronchiolitis because of RSV, respiratory syncytial virus. And if a child has fever and dry cough with loss of the sense of taste or the smell in an older child, it's COVID-19. And when a child has fever, follicular tonsillitis, and tender cervical nodes, think of streptococcus. If there is fever with grunting and rate of respiration which is on the higher side, think of pneumococcus. The child will, be grunting at night like, and the parents will be worried about that. And if the child shows rapid progression, then the child should be suspected to be having staphylococcal infection, where the child will have pneumonia. It will progress to effusion, empyema. There will be pneumatoceles on the X-ray, and the child will appear toxic. Beyond 5 years, if there is predominant cough and less of signs, then it is mycoplasma. So with that, my dear friends, you must be able to identify as to what is the organism which is attacking this particular child. And look at this child who came to me during this particular season in the last month, where he was a 4-year-old child with fever of high grade for 5 days, which was not settling with oral medicines. And on admission, he was tachypnic and needed support with oxygen. You can see that on the right side, the pneumonia is developing. And this was a child who had a low WBC count, low platelet count. There was a mild derangement of the liver functions, and the nasopharyngeal aspirate was positive for H3N2. So this was influenza which presented with low WBC and the low platelet count. I will show you 1 or 2 more cases of H3N2, where again the fever went on for 5 days. It was not settling, and a swab showed H3N2. Again, a child where counts were normal. You can see that the X-ray is showing developing pneumonia on the right side, and the CRP was on the higher side, and the nasopharyngeal aspirate showed H3N2. And a year-old child, an infant, came with status epilepticus, fever, cough, cold, and convulsions. And again, the nasopharyngeal swab showed H3N2, and the MRI showed non-specific changes of encephalitis, where CSF was normal, and we labeled it as influenza encephalitis. So, my dear friends, whenever a child comes to you after 5 days, gets admitted, gets involvement of the lower respiratory tract, then you are fully justified in sending the throat swab. And as we can see, we will give him Oseltamivir, which I told you will reduce the complications and the hospitalization. Now, this girl, who was a daughter of IT sector parents and 7-year-old, came for high fever for 3 days with irritation of the throat. She had examination 2 days later. The throat was showing mild congestion. We gave simple paracetamol with flu and adenovirus around. The parents were after us and asking us, sir, will you do the hemogram? Will you send the throat swab? Will you give Oseltamivir? I told them that this is a viral infection. Whether it is flu and adenovirus, we are not much worried because the presentation is mild. Remember, for all these viruses, the grading of the severity is important. So if it's only mild fever, cold, and cough, you're not worried whether it is flu or whether it is COVID or adeno. If it is mild, we are going to wait. But at the same time, we are going to inform the parents that this particular child has to be observed for the respiratory rate and saturation. Thanks to COVID, many of us have now pulse oximeters at the house. And you can also request the parents to keep one at the home, and then they can monitor. So in case if the child worsens, meaning thereby the respiratory rate increases, or if the saturation drops, or the child becomes distressed, then obviously they have to come to the hospital. And that is the time when we are going to think of all those other investigations and treatment. However, As I told you, if a child, maybe a 3-year-old boy with cough for 1 week and high fever for 3 days, with crepitations indicating involvement of the lower respiratory tract, was put on amoxicillin or amoxiclav by someone and is admitted for persistent fever, and after admission put on IV medication, and the CRP being normal, a throat swab showing influenza A, oseltamivir has to be added. Now the question is whether a child should be given antibiotic in addition to oseltamivir, because it's extremely difficult to differentiate viral pneumonias from bacterial. And my dear friends, remember 25% cases of viral pneumonias have co-infection. So an influenza patient with low respiratory involvement, 25% will have either Streptococcus pneumoniae or might be having Staphylococcus. Okay. Now, when the diagnosis has been done and it has been proved that this child has influenza, if the younger sib comes in the morning with high fever for 1 day, then you are fully justified in starting oseltamivir for the younger sib, because there is a direct connection with the contact. And remember the concept of RO. RO is nothing but the transmissibility. So a child with influenza, suppose, will spread the infection to another 2, 3, 4 children. A child with measles may spread it to another 5, 6, 7, 8 children. A child with COVID again can spread it to about 3 or 4 children. So the number RO is important. And for all these viruses which I just told you, this particular point has to be remembered, that children will spread it to the people around. And if the father is a diabetic, if mother is pregnant, if the grandparents have either asthma or some disease for which steroids are going on, they're all immunocompromised. And if the child spreads flu from him or her to the people in the family, these people who are immunodeficient will have a tough time. And that is the reason exactly why we wish to control influenza in children by giving vaccine, and also control influenza in children by giving them early therapy with oseltamivir. So we should know what are the details of this virus. I call this as KYC, that is know your customer, just as we have to submit our Aadhaar card and PAN card in the bank and prove that you are the one. Similarly, we must know as to what are the features of this virus. Remember, it is an RNA virus. It's a naughty virus. Why naughty? Because RNA viruses keep changing their structure every year, and COVID changes its structure much more often. We have seen so many variants of COVID, and even right now there are some areas where variants of COVID are circulating. So remember that it's an RNA virus, and that is why the structure changes. And I told you in the beginning that those proteins which are present on the outer side of the virus are the ones which show minor changes in the amino acid sequence. I also told you about the major pandemics which have occurred. And recently we have witnessed that H3N2 is the one which is connected with the high fever and the cough cases going on in the community. And the cold wave and the fog and the rising pollution have triggered a surge in the seasonal influenza cases. Now remember that influenza till now was considered as a disease of monsoon and also in the post-monsoon period. But now it has become a perennial, year-long condition. And the surge in the cases of high-grade recurring fevers, many of them are attributable to influenza. And H3N2 is very much in the air, and the infection in the pediatric patients is many times dragged. So whenever a child comes with runny nose, fever and cough, with severe pain in the body, headache, and also with weakness, then you must remember that it could be influenza, and you have to give him empiric oseltamivir. ICMR in the earlier 3 months of the year gave us statistics where it showed that H3N2 is the one which is the major virus which is in circulation. And there have been quite a few healthcare related challenges related to all those viruses, wherein we are forced to use the mask and have increase in the intake of fluids and take care that the people around do not get the infection from our side. And as regards the seasonal variation of flu, there has been a study which was published in the Indian Journal of Medical Microbiology, which shows that the influenza positivity starts with the onset of monsoon and peaks during the post-monsoon period. Now, if you take an overview of influenza in India, the incidence of influenza and the related deaths has been increasing alarmingly in India. Okay, and that's why you should know that this influenza virus, which is one of the most common infectious diseases caused by influenza viruses, is highly contagious. I told you that it's an airborne disease. It occurs in seasons and manifests as an acute febrile illness, and the illness could be mild to severe, and serious outcomes of flu infection can result in hospitalization or death. You can see that the types of influenza viruses predominantly are three. Of course, influenza A is the one which is responsible for the pandemics. I will tell you one important point, that this influenza A is present in the birds as well as in the animals like pigs. It is also present in human beings. But when we need to have some situation where there is a mixing of the flu virus from the birds and from the human beings in the body of the pigs, then the pigs act as a mixing vessel, wherein the viruses from the birds and the human beings, they mix up and a new virus is produced. Okay, and the total change of the structure of this virus occurs. Okay, so remember that whenever there is a major change, this is called as a shift, which is responsible for pandemic. It doesn't occur very often, but it occurs at an interval of 10 or 20 years. And as I told you, the different years when all those pandemics occurred all over the world. Okay, so in case if Pramod suddenly becomes Bhaskar, it's a total change. There is no connection. But if Subir becomes Prabir, then there is at least some similarity. So that the first situation is a shift, while the second situation is a drift. Okay, remember that major change and the minor change. Influenza B infects only human beings and produces local epidemics. It doesn't exist in animals. Obviously, there is no question of mixing, and that's why pandemics will not be attributable to influenza B. And influenza C infects human beings and the swine. However, the infections are mild. The respiratory infection is mild, and it is not the one which is associated with epidemics. Right now, all those viruses circulating are either H1N1 or H3N2. And as I told you, the transmission is up to 6 feet, and the viruses are spread mainly by the droplets when people cough or sneeze or talk. And these droplets can land in the mouth or the nose of the people who are nearby. And that's why one should stay away from the affected person. And if a person is affected, he should stay at home. And it's also important to wash the hands with soap and water. And most of the healthy adults, they will spread the virus one day before and 5 to 7 days after becoming sick. And children may pass on the virus for longer than 7 days. That's why children are the ones who are responsible for the spread of this virus to a greater extent. Now, as I told you in the earlier part of my talk, the symptomatic differentiation of various viruses is very difficult. You cannot differentiate flu and parainfluenza and the adeno and the human metapneumovirus and so on and so forth. But even in the influenza-like illnesses, if this is ILI, that is influenza-like illness, or H3N2, or it is severe acute respiratory infection, or COVID, one has to be very, very careful. In general, just remember that fever and muscle pain and cough and weakness and sore throat and breathlessness, they are the ones which could be seen in almost all of them, because flu and COVID, both of them, they will involve the lower respiratory tract. Most of the other viruses, like rhinovirus, they do not attack the lower respiratory tract. Adenovirus, yes, I told you it produces pneumonias and effusions also. Okay. However, the loss of smell and loss of taste is attributable more to COVID-19. Diarrhea is also seen more common in COVID-19. However, headache is the one which is more predominantly seen in influenza-like illnesses or H3N2. Remember the important point, whenever a child comes to you with influenza, the parents will almost always lift even an older child and bring the child to the clinic, because the child has a lot of muscle pain. And that is why the ILI cases, the cases of influenza-like illness, have been categorized, where we can have either mild case with only fever, cough, and cold, or a case where there is only increase in the respiratory rate, or a child where there is respiratory distress. And the most important thing is you need not worry about what is the virus, but you should know the danger signs. You must be able to tell it to the parents that if the child starts breathing fast, or has cyanosis, or not drinking enough, or not waking up, or not interacting, or is so irritable that does not want to be held, or the fever disappears for a while and then again returns with worsening of the cough, indicating secondary bacterial infection. So these are the things which you must tell the parents, because flu is associated with certain complications, and I have enlisted them with an alphabet A, that is ARI, that is acute respiratory infection, which could be pneumonia or ARDS, acute otitis media, absenteeism from the school or from the work affecting the amdani, that is the income, and antibiotic abuse, because one is unable to differentiate whether it is viral or bacterial. Okay. And the respiratory complications, as I told you, includes otitis media, which occurs in almost 10 to 15% of children. Pneumonias, particularly primary viral pneumonia in children with underlying risk factors, particularly under the age of 2 years. And these are either Streptococcus pneumonia or Staphylococcus aureus. And respiratory complications also include respiratory failure and acute laryngotracheobronchitis and exacerbation of bronchial asthma. There are problems like toxic shock syndrome, myocarditis, and pericarditis. And as I told you, the case of encephalitis, and one of the severe types is called acute necrotizing encephalitis. Children can simply come with a simple febrile convulsion, or encephalopathy related to the cytokine dysregulation, or Guillain-Barré syndrome, or aseptic meningitis. So one has to be careful that influenza can produce these neurological complications. And I told you that myositis, that is pain in the muscles and inflammation, which is seen more with influenza B, occurs in boys between 6 to 9 years of age, and both the gastrocnemius and the soleus on both the sides are involved. And there is severe calf muscle pain and inability to walk, and this is attributable to the rhabdomyolysis. And then the hepatic involvement, particularly if you give aspirin to a child with influenza B, and this is Rye syndrome, producing a problem which is akin to the liver cell failure. Okay, and that's why management of influenza is extremely important. And here comes the importance of the bed rest and increased fluid consumption and cough suppressants and antibiotics for milder cases. You can use non-steroidal anti-inflammatory agents for fever and myalgia. However, avoid aspirin. And most of the patients with influenza recover in 3 days, but the weakness may persist for weeks. And severe cases may require IV fluids after hospitalization, along with other supportive measures. But the most important is the neuraminidase inhibitor Oseltamivir, which is very, very important to be given in the first 48 hours. It inhibits that neuraminidase, which I told you, that is the N from H and N. And this neuraminidase is the one which is responsible for releasing the viral particles from the host cell. We all know that viruses are perfect parasites. They cannot survive without the respiratory cells. So when they are in association with the respiratory cell, they are able to replicate. And from the cell of the host, they will try to release more and more copies to other parts of the respiratory system and the surrounding cells. This particular process depends on this neuraminidase enzyme, which is blocked by Oseltamivir. So it blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. And remember that this Oseltamivir is a selective inhibitor of the neuraminidase enzyme, and particularly for viruses A and B. Oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver. It inhibits the influenza virus replication and prevents further spread of infection. And already I told you the fact which is shown in this picture, wherein you can see on the upper part the virion and the release of new virions from the cell, continuing the viral replication. But Oseltamivir is blocking the release of virions. You can see the red cross. and that is because of the neuraminidase inhibitor, and the viral replication has been halted. So the progression of the disease has been halted. So the disease is controlled faster, complications are avoided, hospitalization is avoided, and the mortality is avoided. This was the first oral neuraminidase inhibitor which was approved in more than 100 countries, and this is extremely important that you know the dosage and the recommendations. For adults, we have 75 milligram capsule to be given twice daily for therapy. And in children, now we have a 30 milligram capsule, and children under the age of 15 kg require 60 milligrams. That means one capsule of 30 milligram in the morning and one in the evening. For children between 23 and 40 kg, you need 120 milligrams. That is 60 in the morning, 60 in the evening. So 30 milligram, 2 capsules in the morning, 30 milligram, 2 capsules in the evening. So very convenient, okay? And for prophylaxis, particularly to be given to patients who are high risk, which I told you earlier, they require once daily dosage, okay? So remember that the dosage in case of children has to be remembered properly. As we deal with children usually who are 15 kg or less, it is 30 mg capsule twice daily, and the prophylactic dose is 30 mg once daily. So this is dosage convenience. There is no wastage, and the course is also quite economical and pocket friendly. There have been plenty of clinical trials which give the benefits of the use of oseltamivir in reducing the low respiratory infections, antibiotic use, and hospitalization, and reducing the occurrence and the severity of pneumonia by early oseltamivir administration. And when administered 48 hours after the symptom onset oseltamivir, it shows considerable advantages. And the patients with a shorter time to oseltamivir administration, they are discharged earlier from the hospital. WHO also endorses empiric therapy strongly. The treatment should be started as soon as possible, and laboratory confirmation of virus is not necessary, and negative laboratory test for H1N1 does not exclude the diagnosis in all patients. Therefore, you have to give early therapy. And in high-risk individuals who are exposed to a patient with influenza, please consider presumptive or prophylactic therapy with oseltamivir. Even the government of India has also endorsed the same fact, and even the adults who are proven to be positive for influenza are to be given oseltamivir, provided they have community-acquired pneumonia, and the treatment should be started within 2 days of the symptom onset, okay? So remember that the unusual pattern of influenza which we are facing, unseasonal, majority of which are H3N2 and H1N1 and influenza B, the diagnosis can be made very promptly depending on the epidemiology, and treatment can be started early to provide oseltamivir and prevent the flu complications. The empiric use of oseltamivir will reduce the lower respiratory complications and hospitalization and antibiotic use. And many of the bodies have recommended the empiric use of oseltamivir. In addition, one should be aware that flu vaccine is important in prevention of influenza. And you can remember the short form Nescafe, the need, efficacy, the safety, cost effectiveness, affordability, feasibility, and epidemiological considerations. Do you need flu vaccine? Yes, we need, for all the reasons that I told you. How about the efficacy? Yes, if the circulating viruses in the atmosphere match with the viruses in the vaccine, efficacy will be great. How about safety? It's a safe vaccine. Is it a cost-effective vaccine? Yes. Is it affordable? Yes. Is it feasible? Yes. And whether it is relevant to the epidemiology? Yes, because WHO takes care that the strains which are prevalent in the atmosphere in the earlier year are included in the vaccine which is manufactured for that particular batch. Okay. When do we give it? We give it when the baby completes 6 months, the first prick, and we give it when the baby completes the 7 months, that is the second dose. Okay. Whom to give? Basically, we have to give to all the people who are at high risk. I told you, the mothers who are pregnant, people who are above 65 definitely, and also with the people who have some immunodeficiencies and cardiac problems and respiratory problems and so on and so forth. And when you give it for the first time, you have to give 2 doses in the first year, and then one dose every year. And I usually say happy birthday to you along with happy birthday to flu, because every year, even in my hospital, to all the staff members, I give single shot of flu vaccine on the happy birthday of the staff or the nurse, so that they are also protected, because we also must protect ourselves by taking the flu vaccine. So my dear friends, this virus, which is a fast and a furious virus, as was the name of one of the English films, and the onset is abrupt, the transmission is high, the progression is rapid, ARDS sets in fast, the child or the adult might die very fast, and Oseltamivir is the only one which gives you quick relief. And in addition, the preventive measures like sanitization, mask, and social distancing, cough etiquettes, particularly coughing in the elbow, which is called as a Dracula cough, which does not give the viruses on the palms, because we can touch the palms anywhere, spreading the virus. And following Hasta Pancha Sutri, the 5 sutras related to the hand, like washing the hands as frequently as possible, avoiding the handshake, using a handkerchief and disposing it of properly, keeping others at a hand's distance so that the virus doesn't directly attack the nose and the mouth, and avoiding the hand touching to the eyes and the nose and the mouth. These are important things related to the hand. And that's why please start rather doing namaste, which is an Indian culture, and also avoid handshake even when you meet someone from abroad, so that they will also carry the same culture when they go back to the country. And with that, my presentation is over, but we have some questions from our colleagues about the current strain of COVID-19 and how fatal is it in the pediatric patients. Remember, the current strain is known to be associated with conjunctival discharge and itching, but it is not fatal, and children are recovering in 2 to 3 days. Whether Oseltamivir is needed in the flu vaccinated patient. Remember, even if the child has received flu vaccine, the protection is only to the tune of 60 to 70%. So if a new strain comes in the atmosphere and the child is still not protected, and if the child gets flu and starts worsening, Oseltamivir is needed. There is no special precaution, particularly for the use of Oseltamivir, but some patients, they may experience a bit of nausea and vomiting, for whom we can give either some medication like ondansetron or some proton pump inhibitor, so that the vomiting part is taken care of. And also, how long is it safe to prescribe in the patients? Remember, for therapeutic purposes, it is to be given for 5 days, and for chemoprophylaxis, it is to be given for 10 days. These durations are enough. And in case if there are any recent updates in flu vaccination, remember, only the strain has changed of the H1N1 type in the vaccine. Otherwise, most of the vaccine is the same. And the WHO, as I told you, receives the vaccination from 5 different parts of the world, and then it directs the vaccine manufacturers to prepare and manufacture the vaccine accordingly. This goes on. This has been going on for years together, and that's why in the months of April and May, we should vaccinate our children, so that during the monsoon and the post-monsoon, most of the children in most of the states are protected. But for J&K, Jammu and Kashmir, and Tamil Nadu, where we use the northern hemisphere strain, because the monsoon in those areas is at a different time, particularly at the end of the year. And that's why you have to just know what is the seasonality and which is the strain available. However, remember, whichever strain is available in the market, please use it, because the vaccines do not change to a great extent. Okay, so only few changes occur in the vaccine. They do give some protection, but you have to use the currently available vaccine which is available in the market at that particular time. Okay, so with that, I think Mr. Manohar, in case if you have any other additional point which you want me to clarify, please let me know. Otherwise,
No, sir.
yeah, we
So
can.
these are the questions. Yeah, sir. So on behalf of Hetero Healthcare, sir, at the end of this session, I am very much thankful to you for sharing your valuable clinical experience and making this presentation very simple to all the attendees. And on behalf of Hetero Healthcare, also I would like to thank all the attendees for sticking till end of this webinar. And we are confident that definitely the input shared by Dr. Zog will be helpful to you in your day-to-day clinical practice. And with this note, we call it end of this particular video. Thank you very much, sir. Thank you all.
Thank you.